Welcome to the second half of our discussion on chapter 27. We're going to finish this chapter up with talking about pregnancy and childbirth and how the mother's body changes with pregnancy, the process of childbirth. We're going to talk about some postnatal changes in both the newborn and the mother, and then we're going to wrap it up with a discussion on heredity. Now, so far, what we've talked about are the changes that occur in the developing conceptus. All right, so now we're going to look at these dramatic anatomical and physiological changes that happen to a mother's body during this 9-month process of pregnancy. And it's important to remember that each woman, and in fact, each pregnancy is different. Some pregnancies are uneventful, and others have significant medical complications. Some women tend to feel ill, while others tend to feel wonderful. And it's not really feasible for us to cover all of the potential complications, so we're going to concentrate on the most important events. And we're going to conclude this module with the most dramatic event of the process, childbirth. But as far as what happens during a pregnancy for the mother, from a clinical standpoint, pregnancy is going to be divided into 3 trimesters, each lasting 3 months, each of which differs slightly from the subdivisions of embryonic development. For example, the first trimester, if you guys remember, the first 12 weeks of development, all pre-embryonic and embryonic development is going to be completed and fetal development begins. So by the end of this first trimester, the rudiments of all the major organ systems are there, and the fact that the first trimester, this fact makes the first trimester really the most critical stage of development. And so this is also the reason why most of the spontaneous abortions occur during this first trimester, because chromosomal abnormalities may prevent those organ systems from correctly developing. Some women can be unaware that they're pregnant until a good portion of this trimester is over, but some tend to realize that they're pregnant much more quickly. Most women find the first trimester to be plagued with the typical morning sickness, fatigue, and breast tenderness. And there are some women that don't suffer from these typical symptoms, and still others who even experience increased energy levels. Now, during the second trimester, that fetus is going to continue to grow and develop. And the pregnancy usually becomes much more obvious as the uterine and abdomen expand. Many women tend to feel relief from morning sickness during this trimester and may feel more energetic, although some women do tend to experience these continuing symptoms. Reaching the second semester makes many women feel comfortable that the pregnancy is safe, because spontaneous abortion is much less common, especially during this fetal period. Additionally, this is the time period in which many women begin to feel the movements of the growing fetus for the first time, those quickenings. Now, the fetus is going to grow rapidly during the third trimester, and it's going to gain a significant amount of weight. The woman's uterus and abdomen further enlarge, and many women experience completely new symptoms entirely related to the size of the fetus. Backaches, internal organ pressure, all of these internal organs are now competing for space in the abdominal cavity. And what's very common for pregnant women is the weight of this fetus now rests on the urinary bladder, increasing their urge to urinate. And as the delivery actually nears, many women grow more uncomfortable as the fetus tends to settle into a lower position in the abdomen. And here you can see some of these changes in a woman's body that occur during pregnancy. Now, if you remember, during that ovarian cycle, the corpus luteum will degenerate about 2 weeks after ovulation. So the concentrations of estrogen and progesterone will lower rapidly, the uterine lining breaks down, endometrium sloughs off as menstrual flow. If this were to occur during implantation, the blastocyst would be lost in a spontaneous abortion. Now, if you guys also remember, the blastocyst implants in the uterine lining, and then the syncytiotrophoblast begins secreting HCG, human chorionic gonadotropin. And this HCG maintains the corpus luteum so that it will continue to secrete estrogen and progesterone. For this reason, the inner lining of the uterine wall, the stratum functionalis, will continue to grow and develop. And at the same time, HCG hormones that are stimulated by HCG inhibit the release of follicle-stimulating hormone and luteinizing hormone by the anterior pituitary, which stops the normal ovarian cycle. So this high secretion of HCG will continue for about 2 months and then actually decline by the 4th month. But by that time, the corpus luteum is no longer needed because the placenta now takes over secreting estrogen and progesterone. And then for the remainder of the pregnancy, the placental estrogen and the placental progesterone maintain the uterine lining. Now, in addition to estrogen and progesterone, there are other hormones that have important roles. Along with progesterone, relaxin from the placenta suppresses uterine contractions until birth begins. And when labor nears, relaxin loosens the connective tissue of the pubic symphysis and the sacroiliac joints, which allows for greater movement of those joints, and it helps the fetus pass through the birth canal. Now, the placenta secretes a variety of other hormones. For example, human placental lactogen, HPL, or human chorionic somatomammotropin. Somatomammotropin. Gosh, that's a wordful. Now, somatomammotropin, or HPL, helps stimulate breast development and prepares the mammary glands to secrete milk. It actually can affect a pregnant woman's metabolism of glucose by inhibiting the release of insulin, which in turn raises blood glucose levels, allowing more to go to the fetus. A decreased maternal blood glucose level can actually result in fatty acid metabolism by the mother, and a placental hormone that is also created is called melanocyte stimulating hormone, and this is partially responsible for the darkening of the areolae and the nipples of the breast, as well as some changes in skin tone in some women. Finally, the placenta also releases corticotropin releasing hormone, a CRH, and the current evidence seems to indicate that this is important in determining the length of pregnancy and the timing of childbirth. In addition, CRH raises the levels of secretion of cortisol, which is needed for the maturation of fetal lungs and in the production of surfactant. And the placenta's secretion of CRH begins around the 12th week of development, raising significantly toward the end of pregnancy. There are some other endocrine glands that increase secretion during pregnancy. Aldosterone will promote more reabsorption of sodium from the kidney tubules, which makes water follow, leading to an overall increase in blood volume. Parathyroid hormone works to maintain a high concentration of blood calcium because the fetus's demand for blood calcium ions is needed to support bone development. Prolactin is going to be secreted by the anterior pituitary to stimulate milk production. And then finally, oxytocin from the fetal and maternal hypothalamus are going to be secreted during the 2nd and 3rd trimesters and peak during labor to stimulate uterine contractions and allow for milk release from the mammary glands. Now, there are a number of anatomical and physiological changes that work to support pregnancy and prepare a woman's body for childbirth and lactation or breastfeeding. And they actually affect multiple organ systems. The reproductive system, for example, has the uterus enlarging greatly over this 9-month period, going upward from its normal location to reach the level of the xiphoid process of the sternum. Before pregnancy, it's approximately the size of a fist, but by the 4th month, it actually fills the pelvic cavity and has begun to push into the abdominal cavity. The bulk of uterine enlargement is actually not because of the developing fetus, but because of hypertrophy of the myometrium, placental growth, and the accumulation of amniotic fluid. Then, in the last few weeks of pregnancy, estrogens promote the formation of gap junctions between uterine muscle cells to facilitate a coordinated contraction during childbirth. By 7 months into the pregnancy, the uterus reaches above the umbilicus, and as the pregnancy will progress, the uterus expands further, displacing abdominal organs upward, compressing the diaphragm, and compressing the urinary bladder. As a result, a pregnant woman may be unable to eat large meals, she may develop heartburn, she may have to urinate frequently. And this increased size of the anterior abdomen changes the center of gravity, and some women will develop lordosis, which is an accentuated lumbar curvature, and that can create those backaches during the last few months of pregnancy. If you guys noticed in that figure, the mammary glands also undergo significant changes in preparation for lactation after birth. Typically, they're very sore during the first trimester because that enlargement that occurs due to the high levels of estrogen and progesterone. Glandular tissue grows, the alveoli that produce milk develop, all of these under the influence of the prolactin, and typically the breasts will enlarge because there's an increase in glandular tissue and adipose tissue that tends to accumulate during pregnancy. Now, this growing placenta requires an increased blood volume, right? And as the offspring grows, it needs more oxygen, produces more waste, all of which has to be removed. These changes cause a woman's blood volume and subsequently her cardiac output to increase. Blood pressure tends to rise, but typically what happens is women will have a lower hematocrit or number of erythrocytes than non-pregnant women. This makes their blood slightly thinner, and it can decrease resistance and tends to prevent a significant rise in blood pressure. As the uterus grows and presses on pelvic blood vessels, venous return from lower limbs may be impaired and can cause varicose veins or leg swelling or edema. Now, because of these close association between maternal and fetal circulations, there can be complications that arise when they do not work properly. One especially prominent complication is preeclampsia. And this occurs in approximately 10% of pregnant women in the U.S. And preeclampsia, though the causes are not necessarily known, they're suspected to be insufficient blood flow to the uterus or a problem with the mother's immune system. This occurrence tends to be related to the number of fetal cells that enter maternal circulation, and it will lead to the fetus being deprived of oxygen, with the mother developing edema, hypertension, and high protein levels in the urine, or proteinuria. Now, undiagnosed preeclampsia can lead to eclampsia, a potentially fatal condition that results in seizures and puts both the mother and the fetus at risk. Unfortunately, the only treatment for preeclampsia is to deliver the baby, but once that is done, the condition tends to resolve within a few weeks. Now, as I already mentioned, more oxygen is needed during pregnancy, and more carbon dioxide is produced to be exhaled. Progesterone makes the medullary respiratory center more sensitive to carbon dioxide, stimulating more removal of carbon dioxide by the blood and increasing the rate and depth of ventilation. However, during the latter part of pregnancy, the uterus can actually prevent the diaphragm from contracting completely and the lungs from expanding completely. Other effects on the respiratory system are mediated well by estrogen, which can actually cause the nasal mucosa to swell, resulting in nasal congestion and occasional epistaxis or nosebleeds. These changes can actually contribute to a shortness of breath in some pregnant women. Now, good nutrition is necessary for a normal developing fetus. A pregnant woman typically needs more than about 300 extra calories per day to sustain both herself and the fetus. Specifically, she needs lots of protein, calcium, iron, and folic acid. The increased intake of food, increased water retention, and the growing fetus tends to lead to a weight gain. The average weight gain is about 28.7 pounds, but there are significant differences from woman to woman. During the first trimester, many pregnant women suffer from this morning sickness, nausea, and sometimes vomiting that occur during the morning. They can occur during the day as well, and these symptoms are thought to be related to the elevated human chorionic gonadotropin, the higher estrogen, and the higher progesterone levels. But there's no truly definitive cause that's been identified yet. Because some women can suffer from an extreme form of morning sickness called hyperemesis gravidarum, and this results in excessive vomiting that leads to dehydration, electrolyte balance, and weight loss in the mother. Severe cases of hyperemesis gravidarum require a hospitalization and IV fluids. On the other hand, some women experience weird food cravings or food aversions for reasons that aren't fully identifiable. It's thought to be related to the fact that some foods, like bland carbohydrates, can contain fewer toxins and are therefore safer. For example, some women tend to crave fruits and vegetables while they lose their interest in caffeinated or spicy foods. There's another digestive system effect that is linked to progesterone, and that is, if you guys know, progesterone relaxes smooth muscle of the GI tract, and this can actually slow peristalsis, resulting in maternal constipation. Now, the fetus is going to produce metabolic waste that the mother's kidneys have to excrete. These wastes, combined with the mother's high blood volume, cause glomerular filtration rate to rise by up to 50%. Now, even as more urine is being produced, progesterone still signals the relaxation of smooth muscle, and so this can actually slow the movement of urine out of the kidney and into the bladder. It slows that smooth muscle contraction of the ureters, and the ureters tend to compress the urinary bladder as it expands, and so this can actually lead to stress incontinence or the unintentional loss of urine. Now, there are also some changes in the skin during pregnancy that may be more apparent in some women than others. Some experience an increased pigmentation around the eyes and cheekbones, forming a sort of mask-like pattern called chloasma. In the areolae of the breasts and along the midline of the lower abdomen, you'll see some darkening. Some stretch marks or striae may occur over the abdomen as the uterus enlarges and the elastic fibers in the dermis will break. In addition, you'll see some progesterone and estrogen decrease the normal hair loss of some women, creating a thicker hair during pregnancy, and nails can actually become stronger and thicker or more brittle and fragile. It could go either way, but hair and nails typically return to normal during the first 6 months after childbirth. Pregnancy is going to end with parturition or childbirth when the fetus is expelled from the uterus through the vagina, or when it is removed via C-section. Now, this series of events that expel the fetus are collectively called labor. Although birth is estimated to take place during week 38, it can occur either 1 or 2 weeks earlier or later. And the series of events are relatively complicated, but they tend to proceed as follows. What happens first is the fetal adrenal cortex produces cortisol, stimulating the placenta to secrete high levels of estrogen. And this is going to, after that, you're going to have the rising estrogen levels that stimulate the formation of additional oxytocin receptors on the myometrium. It also overrides the quieting influence of progesterone on the myometrium. So the myometrium now becomes irritable, leading to irregular contractions. These Braxton-Hicks contractions are often called false labor contractions because they do not result in the 3 stages of labor. Some women experience strong Braxton-Hicks contractions, and because of this, they think labor has begun, but true labor results in uterine contractions that increase in intensity and regularity and cause changes in the cervix. Now that the uterus has more receptors for oxytocin, the fetus and the mother both increase oxytocin production, causing the placenta to produce prostaglandins. And this can lead to early, usually weak, contractions of the myometrium. After this, these prostaglandins cause the cervix to open or dilate, and this is necessary for the fetus to exit the uterus. Both prostaglandins and oxytocin cause uterine contractions to progressively get stronger and more frequent. Now, as the head of the fetus pushes on and stretches the cervix, more oxytocin is going to be released. As more oxytocin is released, the myometrium contracts more forcefully, the placenta secretes more prostaglandins. Both of these cause the cervix to stretch more, which stimulates more oxytocin to be released in a sort of positive feedback loop. Now, during pregnancy, high levels of progesterone lead to the formation of a mucus plug at the cervix. And when this cervix begins to dilate, the mucus, which may be clear or bloody, is going to be discharged into the vagina. Labor may begin within hours after the mucus plug is discharged, or it could not occur for up to 2 weeks. Now, in some pregnancies, labor does not begin as it should, or for some reason, the mother wants to choose the time she gives birth. In this situation, labor is actually induced in a clinical setting. Prostaglandin gels can be applied to the cervix to stimulate dilation, and an IV solution of synthetic oxytocin called pitocin is administered. And here you can see some of these processes that we talk about. Fetal cortex produces cortisol, stimulating the placenta to secrete lots of estrogen. The estrogen stimulates the uterus to form oxytocin receptors. The fetal hypothalamus and the maternal hypothalamus create more oxytocin, stimulating prostaglandin creation. Prostaglandins dilate the cervix, along with oxytocin, increasing the strength of uterine contractions, and with cervical stretching and the fetus pushing on the cervix, you get more oxytocin, more prostaglandins being created. And it just the whole cycle that repeats. Now, labor is divided into 3 stages. There's dilation, expulsion, and placental stages. So in the dilation stage, this is the time from the onset of labor until the cervix is fully dilated to 10 centimeters. 10 centimeters in diameter. When labor begins, contractions originate in the upper part of the uterus and move toward the vagina. As labor progresses, contractions become stronger and the lower part of the uterus actually becomes involved. Now, dilation is the longest stage of labor, but its length tends to vary. It can be between 8 to 24 hours in some women having their first child, and between 4 to 12 hours in some that have in previous mothers. As long as the fetus is in the vertex or head first presentation, the fetus's head is forced against the cervix, helping it thin and dilate. At some point, the amnion is going to rupture, releasing the amniotic fluid. This is what's known as the breaking of the water or rupturing of the membranes. If it doesn't rupture on its own, it may need to be ruptured manually. Toward the end of the dilation stage, the head of the fetus enters the lesser pelvis, and the fetus will rotate so that its head can pass through the pelvic outlet. And you can see this here. This is the normal position of the fetus before labor begins. And then you see it begins to press on the cervix, and it's fully dilated to 10 centimeters, and it rotates its head to get into birthing position. Now, during the expulsion stage, this is from full dilation to delivery. Once the cervix is fully dilated, strong contractions occur very frequently, often assisted by the mother voluntarily contracting her abdominal muscles or pushing or bearing down. This can take a few hours, but typically ranges from 30 minutes to an hour. Now, when the first part of the fetus's head distends through the vagina, crowning has occurred. And sometimes what can happen here is an incision called an episiotomy. A physician will widen the vaginal orifice by cutting a controlled tear or creating a controlled tear through the vaginal orifice, and the fetus's head is then born, followed by the rest of the body, which can be delivered more easily. The umbilical cord tends to be cut, clamped and cut. Now, for some reasons, if vaginal delivery is not possible or is unsafe for the mother, in a breech birth or buttocks first or some other non-vertex position, labor can last much longer. Complications can arise like the umbilical cord wrapping around the fetus or becoming compressed. In any of these cases, a cesarean section or C-section may be performed, in which an incision is made through the abdominal and uterine walls in order to safely remove the fetus and the placenta. In most cases, delivery in subsequent pregnancies can also require C-section, although vaginal delivery after a prior C-section can be an option. And here you can see the expulsion stage. This is well past the crowning event. The head has been fully birthed. The shoulders are well on their way out. Now, after the delivery of the newborn, the placenta and the attached fetal embryonic membranes, collectively referred to as the afterbirth, are going to be delivered. The uterus will continue to contract, compressing uterine blood vessels to limit bleeding and pulling the placenta away from the uterine wall. This takes about 30 minutes, although what can happen is a healthcare provider will simply just tug on the umbilical cord and manually remove the afterbirth much more quickly. Now, complete removal of the placenta is important to stop uterine bleeding. A retained placenta can lead to significant blood loss for the mother and lead to an increased risk of infection. And here you can see the placenta being pulled away from the walls of the uterus and being expelled from the vagina. Now let's do a test yourself question really quick. Put these events in order. Which ones of these come first? You got the hypothalamus of the mother and the fetus stimulating the placenta to secrete prostaglandins. The fetal cortisol levels increase and stimulate the placenta, releasing estrogen. Prostaglandins and oxytocin stimulate the uterus to contract, and estrogen stimulates the myometrium to form oxytocin receptors. Which of these comes first? Put them in order. All right, B comes first, followed by D, followed by A, followed by C. So remember, fetal cortisol is going to increase, releasing estrogen. Estrogen stimulates the myometrium to form more oxytocin receptors. The hypothalamus of both the mother and the fetus create prostaglandins, and the prostaglandins and the oxytocin work together to stimulate uterus contractions. Now, true or false, the expulsion stage of labor is usually longer than the dilation or the placental stages. True or false? That's false. The dilation stage is always the longest stage. Remember that. Now, if you guys remember, the postnatal period lasts from birth to death. In this section, we're going to look at the neonatal period and the immediate changes of the newborn, both in the newborn and the mother, that they have to go through to regain homeostasis after birth. Now, during the first 4 weeks after birth, the conceptus is in what is considered the neonatal period. This is a newborn or a neonate. Immediately after birth, this newborn has to take on those significant physiological adjustments because now it has to do everything that the mother had been doing, including breathing, obtaining nutrients, excreting waste, and maintaining body temperature. And to determine whether a newborn is adjusting appropriately, its physical status is evaluated at 1 minute and 5 minutes after birth, based on 5 criteria: color of the skin, pulse rate, respiratory level, muscle activity, and grimace, which assesses its reflexes. Each criterion is given a score between 0 and 2, and the total is called the APGAR score. An APGAR of 8 to 10 indicates a healthy baby. Lower scores signify some sort of physiological problem. And here you can see how each criterion is scored between 0 and 2. Now, the first and most dramatic event after birth tends to be the first breath. If you guys remember, before birth, most blood actually bypassed the lungs. So in addition to inflating the alveoli of the lungs, the first breath also causes blood pressure in the lungs to drop and decreases pressure on the right side of the heart. So for this reason, blood flows from the left side of the heart and pushes flaps over the foramen ovale, closing the opening. And so because of this initial change in respiration, fetal circulatory routes are going to be converted to the newborn circulatory system. The neonatal respiratory rate of between 30 and 60 breaths per minute and a heart rate of between 120 and 140 are significantly higher than those of adults. These higher rates are because, compared to adults, neonates have smaller lung capacity and the physical size of their heart in relation to their body is reduced. Now, newborns are going to lose heat more rapidly than adults because they have a larger ratio of surface area to volume. Now, newborns are born with brown adipose tissue, which is a special sort of tissue deposited during the 5th month of fetal development, and it produces heat rather than storing energy. But most of this brown adipose tissue is going to be metabolized and not replaced. But as an infant grows, its metabolic rate increases, and it accumulates more subcutaneous adult adipose tissue, which helps insulate against heat loss. Now, although the kidneys are almost fully developed, they're less capable than adult kidneys at concentrating urine. So newborns have a higher rate of water loss and require more fluid intake. It helps that their main food source is liquid during this first few months of life. And most babies tend to be born with a near adult level of immunoglobulin G antibodies, and these are acquired passively from the mother through the placenta. However, maternal immunoglobulin G tends to break down very rapidly and is gone at almost 1 year after birth. Depending on the disease, maternal immunoglobulin G can be sufficient to prevent infection until the infant's own immune system has developed. And in addition to that, breastfed infants also receive an added protection from gastroenteritis thanks to immunoglobulin A antibodies in the first milk or the colostrum. Now you've also got some nervous and skeletal changes during the first year. This nervous system grows very rapidly. Many neurons develop a myelin sheath, and for the skeleton, various areas of it tend to be cartilaginous rather than ossified. Over time, these areas are converted to bone. And there are some infants born with congenital malformations, which are just anatomical malformations at birth. Two especially important ones are patent ductus arteriosus and patent foramen ovale. Now, failure of the infant's ductus arteriosus to close results in patent ductus arteriosus. And this condition can cause difficulties because it allows oxygen-poor blood from the pulmonary artery to mix with oxygen-rich blood being carried by the aorta. This condition can also cause an increase in pulmonary blood pressure that can very easily damage the heart or the lungs. If it's not corrected, patent ductus arteriosus can lead to cardiac dysrhythmias and possibly heart failure because the heart has to work much harder to supply blood to the body's tissues. Similarly, if an infant's foramen ovale does not close because the septal flaps fail to seal after birth, patent foramen ovale results. As the heart grows stronger, the patent foramen ovale also enlarges. In most cases, there are no symptoms and treatment is easy. No treatment is prescribed. However, there is increasing evidence that shows that in adults, patent foramen ovale is associated with strokes because it can increase the formation of inappropriate clots. Patent foramen ovale can also increase the risk of migraine headaches. Now we're going to shift our focus to the mother. For the first 6 weeks following birth, this is the postpartum period. The woman's body undergoes several changes, returning to pre-pregnancy homeostasis, and begins with maintaining the production of breast milk. Most of these changes are completed within 6 weeks, but lactation can continue for up to 1 year or more. Now, just as the mother's body changed during pregnancy, those adjustments occur after birth to reverse changes and restore homeostasis. Immediately after birth, endorphins are going to be released by the pituitary gland that allow the mother to ignore fatigue and pain and take care of the new infant. However, this endorphin production tends to be short-lived, and those positive feelings will soon dissipate. In addition, within a few days after birth, estrogen and progesterone levels fall significantly because they're no longer needed to maintain the uterine lining. CRH, corticotropin-releasing hormone levels, also fall because the placenta is no longer present. And then sudden reductions in levels of estrogen, progesterone, and CRH have been linked to a severe form of depression called postpartum depression. Women who suffer from this condition can require medical treatment. And there's no stigma on this because this is a hormonal balance. This is a failure of the body to simply synthesize hormones, creating a neurological change. Now, for most women, the respiratory and digestive systems resume normal function because oxygen needs and nutrient needs return to pre-pregnancy levels. Respiratory and digestive systems are no longer compressed, and the digestive system symptoms associated with pregnancy like nausea, vomiting, heartburn, and constipation usually stop with childbirth. Now, some of the excess volume retained in the mother during pregnancy is going to stay there. More of this fluid is going to be removed as lochia, a sort of bloody yellowish discharge that is expelled from the uterus for up to 6 weeks after birth. Lochia can usually be heavy for the first week and then lighten for the remainder of the time. The urinary system removes even more excess fluid. When CRH levels decline, aldosterone levels also decline, and urine production increases. When fluid volume returns to normal, cardiac output also returns to pre-pregnancy levels. Other changes, like the altered pigmentation in the skin, tend to return to pre-pregnancy state. The thickened hair is usually temporary, as many women actually experience a significant hair loss after pregnancy. However, some of these changes, like stretch marks and varicose veins, can be irreversible. Now, Lactation is going to be the production and release of breast milk from the mammary glands. In the last month of pregnancy, lots of placental estrogen and progesterone and human HPL stimulate the production of prolactin from the anterior pituitary. Estrogen in combination with prolactin stimulate the alveoli to grow in the mammary gland and the lactiferous ducts to branch. However, high levels of estrogen and progesterone prevent the actual production of milk. For the first few days after birth, however, the mammary glands will secrete a thick, yellowish fluid called colostrum. Colostrum has very little fat and less lactose than milk, but it can contain lots of proteins, and it is very rich in immunoglobulin A antibodies. These antibodies protect the mother from the mother, provide passive immunity and protection against certain infections like ear infections or respiratory syncytial virus and GI viruses that could cause diarrhea in the newborn. A few days after birth, true breast milk will start to be produced because the placenta is gone, estrogen levels and progesterone levels decline, and prolactin activity is not inhibited. And breast milk has a high fat content and contains lots of essential fatty acids, growth factors, enzymes to help digest the milk, immunoglobulin A, and immune chemicals like complement proteins and interferon. Infants are easily able to digest and absorb this breast milk. And breast milk also acts as a mild laxative and helps cleanse meconium, a sort of tarry green fecal material made of bile and other wastes that is first experienced by the newborn. Meconium removal is important because fetal red blood cells break down rapidly after birth, and so bilirubin can really quickly accumulate in an infant's tissues, causing jaundice. Now, oxytocin is what's going to be responsible for the actual ejection of milk from the alveoli. This is a process called the letdown reflex. And letdown actually occurs when oxytocin binds to the myoepithelial cells surrounding these milk glands, causing them to contract and eject milk. During nursing, oxytocin also stimulates the recently emptied uterus to contract, helping return it to pre-pregnancy size. And continual milk production is going to be a positive feedback loop, where it depends on the mechanical stimulation of the nipples, which is actually provided by the infant suckling. Mechanoreceptors in the nipple trigger the secretion of prolactin bursts, which stimulate the production of milk needed for the next feeding. Interestingly, suckling also tends to inhibit the release of gonadotropin-releasing hormone, which decreases the release of FSH and LH from the anterior pituitary. Both of these inhibit the ovarian and menstrual cycle. And so for a certain period after birth, a breastfeeding woman will not ovulate or menstruate. Milk production tends to recede when the infant is no longer suckling, and at that point, mammary glands may return to their pre-pregnancy state. And here you can see this cycle that I'm talking about. The infant suckling triggers the production of oxytocin by the mother, which then stimulates the production of prolactin. And then oxytocin, which is also created, stimulates the myoepithelial cells to contract, letting down more milk. Prolactin stimulates the mammary glands to produce additional milk. And this positive feedback loop is created where the infant is allowed to continue suckling. More milk is going to be created. Now let's look at some heredity stuff, and then we'll be done. So, how exactly does a single-celled zygote become a human made of trillions of cells? And how does it know whether an individual should have brown eyes or blue eyes or red hair or blonde hair? These answers are the same. It's all in the genes. If you guys remember from the cell chapter, genes are going to be the segments of DNA that code for a specific protein. And proteins are what make up the bulk of the body's structures. So genes are essentially the blueprints for tissues and organs. The genes already are going to be present in that first small cell, and they're in every nucleated cell that is produced thereafter because of mitotic divisions. And although all healthy individuals have the same tissues and organs, the exact blueprint for each person is going to be unique because genes have different variations or alleles that allow for a combination of, any variety. Most inherited traits are actually determined by multiple alleles, and we're going to look here at the principles of heredity and examine the interactions of various genes and their alleles. Now, heredity is going to be the transmission of genetic characteristics from parent to offspring through these genes. And the study of heredity and how things are transmitted, this is called the field of genetics. Collectively, all of an individual's DNA is referred to as the genome. And a genome contains around 20,000 genes with 3.2 billion nucleotides. And these nucleotides are folded and compressed, and they form the 46 chromosomes that are found in all somatic cells with a nucleus. So these chromosomes are going to be paired so that there are 23 pairs of homologous chromosomes in each nucleus. Each pair of homologous chromosomes should contain one from each parent. So in total, each of our cells has 23 maternal chromosomes and 23 paternal chromosomes. And so this is why we get that term diploid, meaning 2 copies of each chromosome. Now, chromosomes 1 through 22 are called autosomes. Each member of a pair of autosomes carries the same genes. But the 23rd pair are the sex chromosomes, the X and Y chromosomes, and they determine the sex of an individual. In humans, a female normally has 2 X chromosomes, and a male has an X and a Y. In this case, the X and Y are not truly homologous because they tend to contain different genes. Now, there is a full set of the 23 chromosome pairs that can be arranged and displayed in what is called a karyotype. And in a karyotype, or to produce a karyotype, cells are chemically induced to divide, and then they're arrested in metaphase. A computer will then arrange the chromosomes into pairs according to their size and structure. Now, the presence of abnormalities in the genome can result in a genetic disorder. There are many of these individual abnormalities that could result in an individual's DNA, coming from a single incorrect nucleotide to the addition or subtraction of an entire chromosome or a set of chromosomes. So let's look at these genes and the genetic makeup called the genotype, and we're going to see how it relates physically to a trait known as a phenotype. Now, if you guys remember, homologous chromosomes have pairs of genes that code for the same trait. These genes are found at the same location called a locus of that chromosome. However, these genes are not necessarily identical. They can have different sequences of nucleotides. And so these variants of one gene are going to be called alleles. So, for example, maternal and paternal chromosomes have genes that code for eye color. They're eye-colored genes. However, one of them may have an allele that codes for brown eyes, and the other has an allele that codes for blue eyes. If 2 alleles code for the same trait, like let's say they code for blue eyes together, they are called homozygous, not homologous, homozygous genes. If they are different, let's say the example I gave you, one codes for blue, one codes for brown, they are heterozygous, meaning that they are different. Now, some alleles have the ability to mask or suppress the expression of another allele for the same gene. This could be considered a dominant allele, and the allele that is masked is known as recessive. Alleles are generally going to be represented by letters, and dominant alleles are shown with capital letters, and recessive alleles are shown with lowercase letters. Now, if we were to look at this concept, we'd look at freckles, and freckles are going to be the result of a recessive trait. I'm sorry, freckles are the result of a dominant trait. So we're going to represent that with a capital F. A lack of freckles is the result of a recessive trait, and so we're going to represent that with a lowercase f. Individuals with capital F are homozygous dominant. Capital F, lowercase f are heterozygous dominant, and those with lowercase f are homozygous recessive. Those who are homozygous dominant will have freckles, and those who are heterozygous will have freckles, only because the dominant allele masks the recessive one. Note that not all alleles are going to be dominant or recessive, and many factors often influence the inheritance of a trait. Also, many genes have more than just 2 different alleles in the population. There are multiple choices for eye color, but each individual only receives 2 alleles, one from each parent. Now, an individual's genetic makeup is called the genotype. The physical expression of a genotype in the form of a trait is the phenotype. In the freckles example, capital F, and capital F, lowercase f are different genotypes, but they produce the same phenotype in the appearance of freckles. The genotype lowercase f would yield a different phenotype of no freckles. And although a heterozygous genotype displays only the dominant phenotype, the recessive allele does remain in their genotype. If this individual reproduces, he or she can definitely pass on the recessive trait, which can appear in the phenotype of the future offspring or future generations. And so here you can see a classic Punnett square where you can see a mother here has, let's say she has dimples, and dimples is a dominant trait, okay? So people with a capital D have dimples, and we have 2 heterozygous individuals here reproducing. And so let's say if this mother has the genotype for a capital D, this father's sperm has a capital D, homozygous dominant, they have dimples. The other 2 you see are heterozygous because we have a dominant egg and a recessive sperm. They're still going to have dimples. The same is said here where you see a dominant sperm and a recessive egg. But down here you see a recessive sperm and a recessive egg create homozygous recessive, and this individual has no dimples. Now there are, relatively few human traits follow a strict dominant recessive inheritance pattern. There is something called incomplete dominance, where the heterozygous genotype results in a blending of the phenotypes that are homozygous. An example would be humans that are sickle cell, the genes that involve sickle cell anemia. Homozygous individuals that have recessive sickling genes have sickle cell anemia and will produce an abnormal hemoglobin called hemoglobin S. This causes red blood cells to bend into a sickle shape. Now, they will block small blood vessels, causing pain, organ damage, and even death. Heterozygous individuals have sickle cell trait, and they make both hemoglobin S and normal hemoglobin. So individuals with sickle cell trait are healthy, but they can experience sickle cell crises, especially if they experience low blood oxygen levels. And individuals that are homozygous for normal hemoglobin, capital S, produce no hemoglobin S. And here you can see a Punnett square showing that incomplete dominance, where we have the sickle cell trait as the heterozygous, and then we have 2 separate homozygous. This individual here would have normal hemoglobin, while this individual would have sickle cell anemia. So this is that incomplete dominance. There are also other human traits that involve multiple alleles. One example is the ABO blood group. If you guys remember, blood type is determined by the presence or absence of AB antigens on the red blood cells. The allele for antigen A is represented as I, uppercase A, while the allele for antigen B is I, uppercase B, and the allele that codes for a lack of either antigen, which is blood type O, is represented with I. And I, you notice, is lowercase and recessive. So we're going to see here a Punnett square. So we see this possible combination of blood group, of blood genotypes and their phenotypes that result. We see capital A results in blood type A because it only has antigen A. Capital B, blood type B, only has antigen B. Capital B, blood type B, and then you see this homozygous recessive trait is blood type O. And remember, an individual only gets one trait from its one allele from its mother and one from its father. And so in this case, we see a mother that is heterozygous dominant for blood type A, and here you see one that is heterozygous dominant for blood type B for the father. And you can see they have a chance to make an AB baby, they have a chance to make a B baby, a chance to make an A baby, or a chance to make a type O offspring. So all of these are possible depending on which gene or which allele is coded in the either oocyte or the sperm. Now you've also got some sex-linked traits that are specifically expressed on either the X or Y chromosome. The Y chromosome contains genes that determine male phenotypic traits, and this can explain why females have the genotype XX and the males have XY. All oocytes carry an X chromosome, right? So female gametes do not determine the sex of an offspring. Sperm cells, however, can carry either an X chromosome or a Y chromosome. So sex determination of an offspring depends entirely on the male gamete. As you guys can see from this scanning electron micrograph, the X chromosome is significantly larger than the Y chromosome. And so the X chromosome holds approximately 5 times as many genes as the Y, including genes that code for traits other than those that make an individual female. Unfortunately, there are alleles for genes on the X chromosome that can encode for harmful traits. And so these are sex-linked or X-linked disorders. There are Y-linked disorders, but they are extremely rare. For example, if a male inherits a trait that is X-linked in disorder, an X-linked disorder, he'll likely express the trait because Y chromosomes don't have a corresponding allele to influence its expression. But a female can express the trait for an X-linked chromosome only if she is homozygous for a recessive allele. A female who is heterozygous for the recessive allele most often does not show the phenotype of the trait, but instead is a carrier of that allele. It means she can pass this allele to her offspring, and if, for example, if she passes it to a female child, her daughter will also likely be a carrier, and if she passes it to a male child, her son will express the trait. Do note that a recessive allele is never passed from father to son because the son receives only the father's Y chromosome. A father, however, can pass on a recessive allele to his daughter because he contributes to one of her X chromosomes. And here you can see the X-linked red-green color blindness. And you see the mother here offers dominant R, and you can see that this is normal red-green vision. But you see that she also passes off the recessive are, meaning that she has the color blindness allele. And so if this mother gives birth to a daughter, she's going to be a carrier. But if this mother contributes to a son, she gives birth to a son, then this is the only X chromosome that she has, or that he has. So this X chromosome, you see, is going to result in red-green color blindness. Nowadays, cells and amniotic fluid are going to be withdrawn and analyzed for testing for chromosomal abnormalities. Many genetic disorders are able to be detected during these procedures, like Down syndrome, sickle cell anemia, hemophilia, and these tests are generally recommended for women who are 35 or older at delivery, as the oocytes are older, which can increase risk for chromosomal abnormalities. They're also recommended for women who know that they or the father are carriers of any inherited diseases, or when possible fetal abnormalities can be discovered on ultrasound. In amniocentesis, this is done between 14 and 20 weeks of pregnancy. There's amniotic fluid that is withdrawn using a needle, as you can see here to the right. Now, similarly, in chorionic villi sampling, this is done between 10 and 12 weeks. There's some chorionic villi tissue sucked out using a suction catheter that's inserted into the uterus vaginally. And it's possible to remove these chorionic villi by inserting a needle through the abdominal cavity as well. But both procedures require an ultrasound transducer, which you can see in the background of that image. And this monitors the location and position of the fetus as well as the movement of the needle or catheter. Now, although the danger or the risk of amniocentesis or chorionic villi sampling is low, there is a possibility that you could always harm the fetus. You're doing a sort of invasive procedure, and you could either stick the infant with the fetus with the needle, or prod the fetus with this chorionic villi sampler. Now, after birth, newborn screening procedures will involve the analysis of blood samples, determining whether this baby has a genetic or metabolic disorder. And there can be prompt identification of these disorders that allows for early treatment and prevention of long-term complications. So, blank are going to be segments of DNA that code for a specific protein, and the human blank includes over 20,000 of these segments. What fills in these blanks the best? Genes are segments of DNA that code for specific proteins, and the human genome includes over 20,000 genes. Now, how many chromosomes are in a diploid individual? How many chromosomes are in a diploid individual? 46 chromosomes. 23 pairs of chromosomes equals 46. All right, that's all we have for chapter 27. That is it for the semester. I will see you guys in the review session, and we'll talk more about this. Good luck on your test. Should be coming up.